Our topic for today is the elimination concept. So in this concept, we're focusing on elimination as a physiological concept, where the term elimination refers or is defined as the excretion of waste products. We know that we excrete waste products through various formats: skin, kidneys, lungs, and intestines. Here we're gonna focus on the elimination of waste from the urinary system and the GI system. And we're just talking about uh, GI system bowel elimination as the process of expelling stool, also known as feces, defecation, having a bowel movement, and we're talking about the other elimination, which is the urinary elimination, where we're expelling urine, or also called micturition, urination, avoiding, peeing. So these are the two terms or processes we're going to explore in this presentation. Again, same like in every concept, when we talk about the scope of the concept, we're thinking, okay, this is what's normal, this is what expected physiologically. We're expecting that by elimination, we're going to have waste formation and excretion. Any problems that are associated with that process is going to create an impairment, impaired urinary elimination, impaired bowel elimination. The underlying reasons may be different. You still have the same problem. You may have incontinence or retention, and we'll talk about this in a minute. You're talking about impairment, irrespective of what are the causes and the underlying causes. You're going to see that you're going to see some differences, some similarities, but the bottom line, we're talking the patient is going to have an altered ability of either forming or getting rid of waste. Okay, interrelated concepts. We saw mobility. We talked in depth about this and how a lack of mobility is going to impact both urinary and bowel elimination patterns. And we talked about peristalsis. We talked about urine stasis. And then we talked about supine position and the ineffective bladder emptying that comes with that. We talked about cognition and relevance to this and how people who are disoriented are going to have elimination problems. We'll talk more about this when we talk about risk factors. The concept of nutrition also, we talked about it, and I'm reminding you here the types of food and fluid we ingest is going to impact stool and urine formation and stool and urine elimination as well. And what your patient comes to the table, diseases are also going to be affecting elimination. Fluid and electrolyte will touch upon, food intake as it pertains to this concept, but the real fluid and electrolyte imbalance and acid-base imbalance is going to be covered in next semester. It goes without saying that we come to this class with a background of anatomy physiology. This is a good time for you to refresh your anatomy physiology around the GI system and urinary system. Specifically, as we said, we're talking elimination, basic knowledge of how that system works would help you uh, recognize how to deal with when the system doesn't work. Your guidance talk in brief about both, and then your para and peri talks also about each one. You have a separate chapter, detailed chapter 46 talks about urinary elimination. Chapter 47 talks about bowel elimination. But Giddens does a very good job of summarizing the concept of elimination. You may see redundancies of information, but it's all pertinent information. I'm going to talk about each one of them in the upcoming slides because I'm going to take them separately and talk about them both. Talk about them each separately. This activity we're going to do in class, and we'll talk about it more. You guys are going to actually talk. When we talk about elimination, we're obviously taking you somewhere, and that place is where what happens if things vary from the normal. So the first thing you talk about is control, and control is your ability to control elimination, whether it's urine or stool, controlling the urge to pee, controlling the urge to poop. Control comes versus incontinence. So when we talk about incontinence, we're talking about loss of control. It's either going to be over urine or fecal incontinence. Then when we talk about retention, we're talking about the unintentional retention, because nobody wants to hold on to urine or stool, and so retention problem will happen at any time. There are problems that are primary within um, the organ, or it could be secondary. We'll talk about them each. Also, we're going to discuss this. And so these are the two: control versus retention. You're talking incontinence versus retention. But then you'll see that the comfort or discomfort, rather, because the process of elimination happens better when we're free from pain, and also it should be a process that happens free of pain. Um, so we'll discuss that. Um, Usually, what happens to cause us discomfort? Constipation is going to cause us discomfort. Bloating is going to cause us discomfort. Diarrhea is going to cause us discomfort. UTI is going to cause us discomfort. Infections and inflammation, mostly you're talking here about inflammatory bowel disorders and how they impact elimination. Chronic inflammation is usually a big problem. In the urinary system, uh, we're talking more than UTI. We're talking about cystitis. We're talking about nephritis. We're talking about pyelonephritis and how they're going to impact the control and retention. Of course, neoplasm is more associated with kind of a blockage, so you'll have a retention problem where tumors that happen in the kidney, in the bladder, in the prostate, all can lead to blockage of urinary flow, mostly for men. Uh, Also, problems with the cancers in the stomach or the uterus for the females can affect elimination. Organ failure is just something we're gonna say here is that, like, kidney failure is gonna end up with no elimination. You'll have that condition and discuss it further down the road in next med-surg courses. So when we talk who's at risk, again, we talk about population in general, then we talk about individual factors that impact uh, specific individuals based on their own problems. And you see they put children, pregnant women, and older adults. I want you to read the chapter. In the classroom, we're going to discuss what's going on with these, and problems with altered elimination and bowel, urinary and bowel both. So we'll discuss this in class. Again, also we're going to discuss individual risk factors because they're intertwined and connected to each other. Okay, urinary elimination. I bet none of you have seen this phone. If you've seen this phone before, probably you've at least 3 decades old. But when we talk about urinary elimination, we all go back to that time where we were potty training, or we've been potty trained. So when we talk normal urinary elimination, we all think of the normal urinary elimination and how the process of waste formation, in this case, it ends up producing urine. And then we talk also about excreting that urine. And there are several structures that play a role in that. And any problem with any of those structures is gonna be um, leading to problems with elimination. Other than the structure, illnesses, conditions will impact urinary elimination and cause urinary problems. And what is our role as nurses in helping those patients restore their normal function and support them for bladder emptying? So how often do we do urinary catheterization? Is it go-to method, indwelling versus in an like intermittent catheterization? What are some of the things that the evidence say are ways to minimize risk of infection from such invasive procedures? So we're coming to this course, like we said, with the scientific knowledge base of the normal function of the urinary system. What constitutes the urinary system? We know it's kidneys, ureters, bladder, and urethra. Why is the urinary system, what's the major function of it? It maintains homeostasis. Homeostasis here is by managing the volume and the composition of the fluids, not how much fluid we retain. It's what's in that fluid. So basically regulates blood for ionic composition. Sodium, potassium chloride regulates pH through manipulation of bicarb and H plus. Regulates the blood volume, regulates the blood pressure, regulates the osmolarity. It also has a major role in production of hormones, erythropoietin being an example. And you've learned in your when you were preparing your drug cards and going through your drug book that kidneys have a major role in excretion of foreign substances, such as your drugs that you were learning about. And you know the kidneys sit retroperitoneally, and they're protected by your lower rib cage. Just refreshing from your health assessment 101. You know also that the kidneys have at the renal hilum, they have the renal artery, the renal vein, and it's kind of like there at that juncture is where um, it pours into the ureter. I'm not gonna go into the details anatomy of the kidneys, but it's important to understand how that small organ works, because any blockage for the blood supply or for the structure is gonna impact the formation and the excretions of urine. I have there hyperlink to nephron physiology. Uh, it's a nice three-dimension presentation, so it will give you an idea how the nephrons played a major physiological role in formation of the urine, and and it's basically the functional unit of the kidneys. It's a funnel, and then there are over 1 million in each kidney, and it's like I think more than 45 gallons of blood a day is filtered through those nephrons. Talking also about numbers, kidneys are like 0.5% of your total body mass, but they receive 20 to 25% of your cardiac output. Again, you're gonna take the kidney or the renal system in upcoming semesters, but if we're discussing medical surgical nursing, it goes without saying that you come to this class knowing the anatomy of physiology. Like, for example, the fact that renin is released and it activates the angiotensin mechanisms, and thus that's how the kidneys increase blood pressure. And then you go to pharmacology and learn about ACE inhibitors and how the ACE inhibitors inhibit the angiotensin, so you understand how that works. Wrapping up this review of anatomy physiology with the nephron, you know that it works on in the process of urine production. There's filtration, there is absorption, there's secretion, and throughout there is the homeostasis at the background, where if the urinary system is performing its job, the patient is maintained in a homeostatic status. Also attached, find a link to a very, very short video about renal filtration. So we reviewed the physiology of urine formation, and we that gives us an insight on what does a normal urine, which is the product of that we expel outside after the urine is formed, what should it look like? We know that the glomerular filtration happens and controls uh, many of the items, the substances, I mean. There are substances that are filtered, there are substances that are reabsorbed, and there are substances that are excreted. And we said that these are basically happening to keep the body in homeostasis, manage pH, get rid of toxic and foreign substances. What's reabsorbed? Water, glucose, amino acids, ions. Talk about filtration. There's like 180 liters of water that passes by the kidneys. Of that, only 1.5 to 2 liters get excreted. Proteins, sodium ions, chloride, bicarb, glucose, urea, potassium, uric acid, creatinine. If you look at the filtration versus reabsorption versus excretion by day, you'll see that there's variation. If creatinine, if it's filtered in the glomerular capsule, 1.6 grams is almost excreted in the urine exclusively, versus proteins. If 2 grams are filtered, only 0.1 gram is excreted. And thus it gives you an idea of what is the urine composed of. Mind you that although we said it's mostly formed of water, we know that we did not excrete all the water. We recirculated most of it. But if we increase our intake of water, you're gonna see that the urine is gonna look diluted, and it's gonna be high volume compared to what? Compared to what is expected. Um, Precision talking, your kidneys excrete 0.5 ml of urine per kg per hour, and so that makes a person who's 100 kilo peeing around 50 mLs an hour, and a person who's 50 kilos peeing 25 mLs an hour. But you learned in the lab that 30 mLs is the average. So can a person pee 100 mLs an hour? Yes, if they're drinking too much, even without the fact of them getting any effect on diuresis. You can ask me this question in class and I can answer you about diuresis. Consequently, reduced intake will make it, if the kidneys are doing their job, that we're going to have less urine output, we're going to have more concentrated urine output, and again, if the kidneys are doing their jobs. So it makes it a given that when we're looking at and evaluating the kidney functions, there are certain um, lab diagnostics that you do by blood sampling, and that would be your creatinine level, your glomerular filtration rate, which is GFR. But if you look at the urine itself, you do a urine analysis and you can guess in that instant whether the urine is abnormal. You don't expect to see albumin or any protein for that matter. You don't expect to see red blood cells. You don't expect to see sugar. You don't expect to see ketones. You don't expect to see microbes. And the presence of any of those will warrant further investigation. And we're talking about urine testing, not blood testing. This is another thing that we're gonna go over in the class. I want you to look at it, try matching um, items on the left column with the items in the right column, and match one to B, for example, and we'll go over the answers in the classroom. Another element that is important to mention when we talk about normal physiology of elimination is the antidiuretic hormone. And I'm gonna keep this slide as a tease. I want you to answer me in the classroom. What would be the correct answer? Is it a decrease or an increase? You will revisit ADH in the last semester when you again talk about fluid electrolyte imbalance and the role of the antidiuretic hormone in the process. Okay, on this second part of your scientific knowledge base and your background anatomy and physiology, you know that ureters are the ones that transport the urine from the renal pelvis through peristaltic waves similar to the GI system, and through hydrostatic pressure and gravity, and that's why you saw that posture impacted urine emptying. You know that there's no valve at the opening of the ureter into the bladder, so that's why we're afraid of backflow. And so when the bladder fills, it can compress that opening and prevent backflow. You know that the bladder is a hollow, distensible muscular organ. Average capacity is 700 to 800. It is mostly formed of epithelial tissue um, that stretches. You know that the trousseau muscle is the muscle that plays a role in how the bladder is going to contract. Um, it is one of the main factors in the bladder is it's a low pressure storage system, and sphincters are high pressure, so they prevent loss of urine, so you don't pee, you don't have constant incontinence, and then the bladder may be the same in males and females, but the anatomy of their urethra is gonna impact their um, bladder emptying, especially where the internal and external sphincters on the urethra are situated. So, like that the female urethra is shorter, and that's why the urban legend of females having more UTIs is not a legend. It's a fact. What else we wanna review? Um, Another fact about the bladder is the fact that it is impacted by autonomic nervous system, and that's where the word neurogenic bladder can come. There's also orchestrated effort between the autonomic nervous system and the somatic nervous system, and thus you have voluntary muscle control, thank God. And what else? We are able to hold in urine with that fact, but the act of micturition is really is a play between three central nervous system control: the spinal cord reflex center, the micturition center, which is in the pons, and the cortical and subcortical centers, all play a role in the bladder emptying. And wait for it, the micturition. So micturition happens because of the work of the detrusor muscle. When the detrusor muscle contracts, urine is expelled from the bladder. Um, we don't feel that there's volume in the bladder until the volume is between around 200, between 150 to 250, depending on the person. And then the stretch receptors in the muscles get activated. When the bladder has around 400, you feel you have that sense of fullness. And so not every time your bladder is stretched, you feel the urge to void. It has to reach the point where the stretch receptors are activated for the micturition center to be stimulated. Remember the micturition center in the pons, in the brainstem, and then the spinal reflex is stimulated, and then you pee. So the detrusor muscle contracts, the internal sphincter relaxes, and the external sphincter gives that conscious control over the urine, and then urine flows out. So we will also use the abdominal muscles to help with the urination. But that reflex, although it's autonomic, and that urge to void, it can be overridden. So it's a conscious act, and I want you to remember this because your patient may hold it, and you may have part of your teaching in when it comes to retention and complications, frequent UTIs. Tell the patient that you need to pee. You don't want to hold it because they have that conscious control over it. What else we want to remember? So that's in a nutshell the scientific background, and so that makes you get a clearer idea about those urinary elimination problem that you're going to discuss with the patient, because you remember the physiology, you know the anatomy, and you know the pathophysiology. So in discussing the common urinary elimination problems, we talked about urinary tract infection earlier in the semester, and in this case, so you're just gonna see it discussed as a consequence of inserting a device, catheterization, mostly when it's an indwelling catheter versus an intermittent catheter where it's in and out. But the two main problems are either problem of control or obstruction, and you get urinary retention, or a problem of lack of control and involuntary loss of urine. Um, so if you have, we'll start with urinary retention. If the external sphincter on the urethra does not open for the urine to get released, you're gonna have increased urine in the bladder and bladder distension, and then eventually there's gonna be backflow up the ureters, up to the renal pelvis. You're gonna see dilation, you're gonna see pyelonephritis. On the other hand, if you see there's a lack of control, you'll see release of urine, skin breakdown, and impact on the daily activities and social um, life of the patient. And so let's continue talking about obstruction. Usually urine is produced, it gets excreted. In this case, you're seeing retention. Which patients? Some of the patients might have congenital obstruction to the urinary meatus. Some may have sacral nerves damage, such as in the spina bifida, and others will have it acquired, like really later on life. prostate enlargement in the male population is a thing. Having fecal impaction as delayed complication of constipation. Tumors can be also a source of obstruction. And any times you have that obstruction, what's happening is the kidney is the body is trying to compensate. The bladder tries to hypertrophy to hold on to that volume. You'll feel patient may have urgency, beginning, maybe leaking or incontinence, but only of small amount. But eventually, if the bladder can't fully empty, you're gonna see that the trusor muscle is gonna fatigue and it's not gonna contract, and then you have the stasis and the urine sitting there. And when the urine sits there, you know that it's gonna be a good medium for the development of infection. Um, and we talked about the backflow and how you're going to have hydroureters or ureters that are filled with the um, urine and kidney damage eventually. Um, Remember, they're talking about urinary tract infection. So there you'll see that many patients who suffer with retention, they're going to have recurrent urinary infections because urinary stasis is kind of synonymous with infection. Another term that you may hear used is the neurogenic bladder, and that describes the fact when the bladder loses that neural control that is normal, so that neural control disrupted, whether it's peripheral nerves or spinal cord impact or pons or the cortical area that is concerned with the act of micturition, any one of them will create a neurogenic bladder. So you'll either see an overactive bladder where the bladder fails to relax and store the urine, or areflexic bladder where the bladder fails to contract and empty. And the great example, you see that in spinal cord injury, you see that in stroke patient. And the bladder can be flaccid where there's too much urine stored, and so it loses that sense of fullness, and the trusor muscle gets overstretched, but there is no voluntary bladder emptying. um, these are some of the problems. And so to prevent overstretching of the bladder, to prevent UTI, to prevent kidney damage, what you see them do is put catheters. And that's one of the legitimate reasons for putting catheter is urinary retention. Urinary tract infections, before we talk about incontinence, I want to say that most UTIs are caused by E. coli, but you'll see Enterococcus, Klebsiella, Pseudomonas. Mostly they're caused by ascending bacteria. They talk about ascending because they go up from the urethra into the bladder. They can go up to the ureters. They're more common in women than men just because the women are the urethra is shorter. They're more common in sexually active versus non-sexually active, more common with people with neurogenic bladder, more common with people with diabetes. So when you discuss risk factors, you know those are risk factors. More common people who have Foley catheter, so they call that hospital-acquired UTI. Remember, I told you, anytime you put a catheter, there's a risk of infection, and the more it stays there, the more the infection rate is going to be increased. What else? You know that the urine is normally sterile, but we will introduce infections through um, um, the insertion of a catheter. So observance of medical asepsis and surgical asepsis is going to be key. The infection of the bladder is called cystitis. Many times the bladder will go and have inflammation, not an infection, and it will have similar symptoms. Um, what else? So we'll discuss pharmacological treatment in general at the end of the presentation. But remember when we talked about prevention of UTI, and these are some of the patients where you are going to work on prevention and consider it a high priority. They do give antibiotics if that is the usual course, like the needed course of action, but most of the time encourage them to drink plenty of fluids, cranberry juice, uh, fluids that have urine acidifying effects, stick to good cleaning measures from front to back. It works, and we're not going to change that in here because we know it works. The last on this slide is urinary incontinence. You have stress incontinence, um, you have urgent continence, you have mixed stress and urgent continence, and you have overflow incontinence. Overflow comes from urinary retention, if you remember. And this is involuntary leakage of urine. And thus the patient can be realizing it or not realizing it. But in either way, they can't control it. And in older adults, it's a common problem. More of so the stress incontinence is more assimilated with bladder pressure exceeding the pressure exerted by the urethral sphincters. Women suffer with this because of pelvic floor muscle weakness. So you would think the patient education around the Kegel exercise, improving the muscles, would work with these patients versus the urgent incontinence where the patient has urgency, frequency, and here is the reason is that the bladder does not completely empty. Mostly because involuntary bladder contractions and such as overactive bladder, patient with stroke, with MS, especially those with lesions at the level of the sacrum, they'll have this. So here you resort to other teaching points rather than asking them to do the Kegel exercise because that's not their main issue. You see mixed incontinence where you have stress and urgent incontinence. Um, um, the major symptom you see on that patient when they sneeze, when they cough, when they laugh, when they lift something, they'll have leakage. Um, and then um, the incontinence treatment is usually more of advocation, Kegel exercise. Teach them how to contract the muscles of the perineum. Um, like that. That's what we do. Uh, but we have some drugs that have worked, especially on urge incontinence, anticholinergic work, but they have side effects. But in general, these are the three main common urinary elimination problems. So you came to the table knowing the anatomy, physiology, and we talked a little bit about the abnormalities or the pathophysiology. Now we're talking nursing. You have to bring forward elements that you've learned up to now. You learned infection control and hygiene. So you wash your hand, apply medical asepsis, surgical asepsis. We've talked about, anything that is introduced to the patient is an invasive procedure and it brings with it infection. You know that the urinary tract is sterile, but if we don't exert those infection control principles, there's going to be development and spread of UTIs. And growth and development, you're learning that the neurological system, for example, is not well developed until certain age, and what comes with the aging as in the muscles and whether it's a skeletal muscle or a smooth muscle. But you're also learning that how does the urine look like, and amount of urine you're expecting, and how pregnancy affects uh, the urinary tract and the changes in the body that comes with pregnancy. And like we said, the normal aging process and its impact. Uh, and staying with the older person, even with the younger person, what is the psychosocial implication on a patient that now has stress urge incontinence or urge incontinence, or the patient that the kid that never gets rid of enuresis, and how do you do toileting skills, and how do you retrain your patient after bladder injury. It is devastating to self-esteem and self-image. So it is an aspect that we have to explore and be able to discuss with our patients. Okay, your book talks about critical thinking. We're going to cover this in detail like next week, and we talk about clinical judgment and the nursing process. But one thing you have to look at is whenever we're looking at anything, we bring um, um, we're assessing the situation, whether we're assessing in the beginning to identify a problem, or we're assessing to formulate our problem, or we're assessing to evaluate. um, at the core of our assessment, where we gather those information, we ask the patient about their history, symptoms, what factors are impacting their condition, how do we perform our physical assessment, do we know what are the characteristics of urine, how do we gather important information, where do we look for labs and diagnostic tests. That assessment is based on 4 criteria you're gonna learn. First, your knowledge. So what we discussed early, your knowledge base, anatomy, physiology, your knowledge of how the urinary system functions is gonna impact your assessment. Because what you don't know, you can't miss. That's um, you know a very well-known fact. So if you did not know what to look for, you're not gonna assess for that thing. Experience, the more you get experience with caring for patients with altered urinary elimination, the more you're going to be able to pick up on hints or things that are going abnormal. Your personal experience are also valuable, and so if you've had multiple UTIs, probably you can talk about it more than somebody else. Then the third place where you bring your assessment skills, or you sharpen your assessment skills, is if you learn about standards. What are some standards? The standard is provide privacy. Patient has the right for dignity, for privacy, for confidentiality, and look at what did professional standards call for. So you're not allowed to use urinary catheter for just anything. You have certain criteria um, that allows you to put a Foley catheter. So the last element your book talks about is the attitude, and we're talking here about attitude, about acknowledging that we have limited knowledge, tap into the person who knows better, respect the patient, learn if there are some cultural preferences, be sensitive that when we're dealing with elimination, especially in elimination, we're dealing with private area. So how is the patient gonna be um, feeling in that situation? For the remaining of this few slides, where we're discussing the nursing process, whether be it assessment, be it diagnosis, be it planning or implementation. I'm going to ask you to bear with me because we're going to discuss this in the class. We're going to do a quick care plan about altered urinary elimination, and we'll see how we're gonna get to the answers to all these questions. So you're gonna follow those hints in your book and on this PowerPoint to formulate a nursing care plan using the nursing process. On page 1176 in your parent pair, you see there's a box that says safety guidelines for nursing skills. And then, so we talked about medical asepsis. Surgical asepsis is a skill that you're gonna learn next semester. But what tops all these is the fact that we have to ensure patient safety in our role as professional nurse. Communicate with your team member, with your patient, make sure that you have your priorities sorted out, your patient preferences, you're using best evidence uh, practices, and um, allergies, for example. What if your patient has latex allergies? Ask them those questions, because if you're putting a Foley, for example, you have to make sure that that Foley is latex free. Sometimes, allergies are juxtaposed, like, for example, if the patient has allergy to penicillin, you're wary of giving them cephalosporin. And similarly, if a person has iodine allergies, you're worried about other um, um, allergies. So but you have alternatives. So you use chlorhexidine in cleaning, although we're using chlorhexidine now. Your book refers to iodine. You rarely use iodine in this um, in since in the last decade, because of allergies to iodine. Anybody that's allergic to fish is gonna be allergic to iodine. And so most of the time you're using chlorhexidine. There's certain population you don't need to worry about when it comes to um, chlorhexidine, sensitivity. Uh, you're gonna be thinking about, okay, when we talk safety guidelines, can we delegate? You can delegate certain activities. For example, collecting urine specimen. You can delegate that to an assistive personnel as long as you follow the 5 rights of delegation, and making sure that there was nothing that was done wrong. One of the major safety with elimination is if you take a urine sample. It's a lab test. So do you know that you have to confirm that the proper identification and proper identification of the specimen is followed, because eventually the treatment is going to be dependent on the result of that uh, lab tests. So if the specimen is wrongly identified, then you're gonna give the wrong diagnosis and eventually the wrong treatment. Bowel elimination is discussed in chapter 47, para and peri. Um, the GI system has more than one function. It breaks down nutrients or food, and then it digests it, and then it absorbs it, and finally it eliminates it. You're focusing on this class on the elimination part of it. and how the body gets rid of those waste products, which is a normal body function. So anything that hinders that process is going to cause alteration. Any alteration in the regular bowel elimination is going to show symptoms: nausea, vomiting, flatulence, cramps, constipation. You're going to see them. And one of the things we have to um, keep in mind and be cognizant of is that this is a very private event, and so you need to be able to respect the patient's privacy, respect their emotional needs, uh, do the things that will promote normal elimination without embarrassing or putting the patient in an uncomfortable position.
So no, the scientific knowledge base is going to help you understand the normal functioning of the GI system. This hyperlink in the slide will talk about how the digestive system works. It's a 3-minute video that really summarizes how food enters the mouth and exits through the anus. Remind you that the large intestine, also known as colon, is where the bowel elimination is happening between the colon of the large intestine and the anus. There's the rectum, and there's the fact that peristalsis movement is involved, and the sphincters are involved, and the gastrocolic reflex is involved in the act of defecation. Defecation, also known as expulsion of feces from the anus, rectum, also known as bowel movement. The peristaltic waves move the feces into the sigmoid column, into the rectum. There's nerves involved. These sensory nerves are stimulated, and then they create the urge to defecate. We have the internal and external sphincters that need to um, relax, and then feces will move into the anal canal, and the external anal sphincter is a voluntary sphincter. That means we control when it's relaxed, and we control when we poop. And then the feces that's expelled is, it's mostly constituted of water, but solids also are there. Bilirubin gives it the color, and then it should be normally a brown, soft, well-formed stool. One thing happens with defecation is if we're not in a place where when we can poop, we inhibit the urge to defecate because we can control the external sphincter. Repeated inhibitions of the urge to defecate usually results in constipation. We hold it, and then there's expansion of the rectum, and then that repeated holding and expansion of the rectum creates that loss of sensitivity, and thus one complication of bowel retention, aka constipation, occurs. The constipation happens because the stool is spending too much time retained in the rectum, and then it dries and hardens. And then we're worried about constipation, yeah, but we're worried more that if it stays, then we're gonna have fecal impaction. Now, as nurses, our knowledge should encompass, those risk factors that will influence bowel elimination. And you see here multiple risk factors. All individuals, regardless of age, gender, race, are at risk. They're all at risk for having altered bowel elimination, but there are populations are at greater risks for bowel and urinary elimination. And we spoke about this: children, pregnant women, older adults. Um, We know that when adults constipation is a problem, that's what we talked before about increasing the fiber diet. The gastrocolic reflex, which is a reflex where the act of eating stimulates movement in the GI tract, and eating large meals or foods with high fat content can increase the stimulation of this reflex and result in more peristaltic movement or intestinal contractions. And that's one um, risk factor specific to older adults. Um, diet, diet that's lacking in fiber is a problem for most individuals. So you'll talk to your patients about increasing fiber. Um, Fiber is insoluble, thus it doesn't attract water, but gives the stool bulk and kind of a laxative effect, helping with the prevention of constipation. Um, Soluble fiber, on the other hand, attract water and slows down digestion. You see it used in weight loss because it makes you feel full. Um, Fluid intake is important. So opposite to this, when the patient has diarrhea and doesn't have and losing fluid, we know what that is gonna do for patients. So fluid loss versus fluid less fluid intake are gonna be two different scenarios. When less fluid intake will cause constipation, but fluid loss will create fluid imbalance, and the patient may be at risk of dehydration. Medications, there are many medications that can cause constipation. Your pain meds are largely at fault. Um, some medication change the appearance of feces. For example, some iron supplements will make your stool look black. Eating too much greeny vegetables, such as spinach, will make your stool look green. Certain medications will alter the color of stools and of the urine. When we eat beets, uh, we may see maroon colors too. So these are some of the things to have in mind about certain uh, elements that affect urinary elimination and affect your assessment when you're assessing, I mean, urinary and bowel elimination, and affect the bowel elimination itself. We talked about colonoscopy, for example, and the fact that one of the side effects is maybe perforation. So diagnostic tests are gonna be also some of the risk factors you're gonna be asking about. The most common bowel elimination problems: constipation, diarrhea, incontinence, and incontinence different than diarrhea, obviously, flatulence, and hemorrhoids. And so constipation, which is defined as the passage of dry, hard, difficult to evacuate stools, and usually the main culprits are either paralytic ileus, decreased muscle strength, decreased level of activity, poor dietary choices, and medications like we talked, versus diarrhea, which is defined as the increased passage of increased number of loose stools, and that could be due to a disease process, a stress, especially prolonged stress. Again, dietary changes if you take high fiber diets, and certain GI conditions, inflammatory bowel diseases, some allergies, poisoning, and intake of stool softeners and cathartics. So, to solve certain bowel elimination problems, such as when we have obstruction in bowels, or when the patient is unable to take food entirely and we need to create gastrostomy. You'll see that ostomies are created. So what is an ostomy? It's an opening in a GI system. You can see also ostomies in a respiratory tract, where you see tracheostomies, and you can see ostomies in the urinary system, where you see um, an opening through the bladder, or an opening from the side of the kidney. It's called nephrostomy. But we're focusing here on the bowel diversion ostomies, and those ostomies will be classified according to their status. Is it permanent? Is it temporary? The anatomical location, an opening through the abdominal wall to the stomach is a gastrostomy. Obviously, that's created for feeding. An opening through the abdominal wall to the jejunum, that's called jejunostomy. An opening through the small bowel, at the end of the small bowel, where the small intestine is attached to the large intestines, that's your ileum, and it will be called ileostomy. An opening to the large bowel is called colostomy. And then for that, you it's good to know that there, in the large intestine, there are multiple places where, depending on the need, a specific case of the patient, the ostomy would be at a different place. You know, there's the ascending column, there's the transverse column, there's the descending column, there's the sigmoid column. So based on that anatomical place, the ostomy will be called sigmoidostomy versus ascending colostomy. And how would the ostomy look like is also of importance for the nurse. You expect it to be uh, pinkish, reddish, moist. Um, expect small bleeding when it's first made, but eventually that bleeding shouldn't be seen. Definitely, you shouldn't expect bluish discoloration. That means it's not uh, it's not um, good, and then some lack of perfusion is happening here. You shouldn't expect a patient to have feelings in there, or if that they shouldn't have pain. Um, and so part of your role as a nurse is to assess those ostomies. So earlier on, we talked about critical thinking and how it is, if used successfully, it's based on your knowledge, experience, and the information gathered from your patient, your attitude, and your intellectual and professional standards. In the case of bowel elimination, you're gonna gather information from your discipline, from other disciplines, and really, from the patient themselves, to understand what the patient is experiencing, and their response to their problem, the altered bowel elimination, and to help you create an individualized plan of care. Um, One of the main characters and your attitude is you have to listen to the patient, and apply those standards of confidence, of creating intimacy, and privacy for the patient. Uh, um, I mean, acknowledging that it's an intimate action, process, and giving the patient privacy. So the nursing process, and the first thing you see in the nursing process always through the patient's eyes. What does through the patient's eyes means to you as the nurse? Um, what we're looking here, we're looking at you um, caring what makes the patient uncomfortable. Um, exposure of the perineal area, because that's where your elimination is gonna be happening. Are you creating any source of discomfort or embarrassment for the patient? Are the patient feeling embarrassed? And then uh, the nursing history focuses on a couple of main elements. What's the usual elimination pattern? How does your stool look like? And you have to be able to differentiate the stool. So when you document, you say, it is, it looks like this, well formed, it's pebbly, it's watery, and then you have this Bristol stool form scale that is used usually to differentiate, and you can ask the patient, you can show this to the patient, ask them um, one of the assessments, physical assessment questions. One of the assessment is some questions which are subjective, as you have targeted questions, uh, about the nausea or the vomiting, what color it was, what makes it feel worse, what initiates it, like as eating certain foods caused it. So, and your book has a very nice exploration of that topic on page 1203. You have a box also 47.3 that gives you a hint of the assessment questions you can ask when you're getting the nursing history. But uh, like really, when it comes to elimination, bowel elimination, there are certain specific topics that you have to focus on, like changes in diet, appetite, type of food, fluid intake, whether any surgery has happened, medication history, exercise, pain, mobility. All these questions you're asking the patient. And then when we're doing the physical assessment, we're assessing from the mouth to the uh, listening to the abdomen inspection. You're looking if there are any ostomies. You're asking the question about how often do they go. You're auscultating for the bowel sounds. Again, your book talks about percussion, and we're gearing away from percussion. Uh, Lab tests. You can ask the patient if they're seeing any blood, but an occult blood test will show that whether there is any bleeding. H&H, hemoglobin, and hematocrit will show also if there is any bleeding. And liver function test, um, enzymes like the amylase, lipase will also give you an idea about those accessory organs that help the GI system function. Um, um, Diagnostic examinations, some of them we can do, some of them we're just assisting in. But also, again, look at the table 47.1 because it gives you an idea of how the characteristics of the stool should look like, the shape, the consistency, the um, frequency. How do you describe this? Um, your book also talk about how do you perform Goyak fecal occult blood tests. It could be performed by a nurse. This is a test that you can perform, and so you should be familiar with those. So that the like I said, the box 47.4 explores that. Diagnostic examination, I said, like you don't perform it, but you assist endoscopies, colonoscopies, you or just a simple rectal exam, you may be there assisting with the test. Nursing diagnosis, we'll talk about these and when if we get the chance, hopefully we do get the chance to create a simple concept map around this, pick one of these problems and explore it a little bit. planning is going to be important to incorporate the patient, the history that we've collected, but also their goals. What is the goal of the patient? And I want to see that when we do the care plan, how would you incorporate the patient uh, goal in your outcome? So you see two different kinds of bedpans, and I'm sure you were exposed to these in the lab. One is called the fracture bedpan, one is the normal bedpan. When the regular, I mean, bedpan. One of the things that you have to understand as a nurse, building on your knowledge of anatomy and physiology, is that the normal defecation to happen, patient has to be in a certain position. Sitting position is the position. So how do you set the patient? How do you put a bedpan? There's um, um, a whole like a step-by-step process in your chapter about how do you put a patient in on a bedpan, and I want you to be familiar with that. Um, so um, again, we're going to talk about as more implementation actions and when we're talking about the concept map in class, but um, couple of major problems we talked about, mm, constipation and diarrhea. What would be your role as a nurse when you're talking about your patient that has diarrhea? You obviously have seen it, that one of the most um, used approach to dealing with the constipation is administering laxatives, and you will administer laxatives as prescribed. And sometimes you're seeing administering enemas, and so you have to learn how to administer the enemas and the different types of enemas. You have the oil retention enema that softens the feces, the soap suds that cause the reflux evacuation versus the tap water that softens the feces and stimulates evacuation. These are the known enemas. Um, Patient education. We talked about sitting position. We um, can teach the patient about, going to the bathroom after a meal. Um, don't overuse laxatives, because then you have a lax bowel. The enemas and their danger of, if the patient administers them or any caregiver administers, that's going to be a risk for perforation. With diarrhea, you're more concerned of the fluid electrolyte replacement, but you also are afraid of the skin breakdown, and so you're working on prevention of skin breakdown around the anus, preventing dehydration, electrolyte imbalance, and maybe also give some um, anti-diarrheal products. Um, the next topic that you need to be familiar with is enemas, and we talked about the different types of enemas. Um, Enemas are not your go-to method of treating constipation. It's more when you're when there is more of hard to expel feces, and so they're used to promote defecation. They stimulate peristalsis, and most commonly used to create an immediate relief of constipation, or emptying the bowels before a diagnostic test. You don't want to take a patient for colonoscopy where there's any stool, because obviously if there's any stool, they're not going to be able to visualize the lining of the bowel. So some are called cleansing enemas, and in some situations it's just purely used to relieve the patient. Who administers the enemas? We do. So we have to know that it's not a sterile procedure. The column is usually not a sterile, like the inside of the column is not sterile. But however, we're applying all the infection control measures. At the end of the day, this is patient's body fluid, so we're worried about this. Positioning the patient. How do you position the patient? Um, is important both for the comfort of the patient and because they have to retain the fluid for a bit before they defecate, and uh, you have to lay the patient in a certain position for the enema to work naturally, normally with that how the anatomy of the GI system is. Um, Usually, you're afraid of putting the patient in any improper position because there are complications, and the tube that you insert for the enema is a cause for may cause injury for the rectal wall. Um, Impaction, this like removal of stool, digital removal of stool is one action that they do. Like you literally scoop the stool because the patients can't defecate on their own. Um it may be a necessary action. Just be wary, but because that digital removal is a last resort and it's only done in severe situations. I've seen it more than that I like to. That when it's being done, the patient may bleed because the area is very sensitive, and you may also stimulate the vagus nerve. The minimum damage you can do is irritate the mucosa around in that area. In your clinical, you were taught or spoken to about administering medication through NG tube, maintaining an NG tube. You saw how they checked for residual and checked for patency of NG tube. You are not inserting an NG tube in this course. You'll learn that in next semester, but just know that you are gonna have patients with NG tube, nasogastric tube. A nasogastric tube is one of the devices that, if not when that has to be held in place and secured, and that tape or the way you secure it and how it's if it's not monitored, it can create a skin breakdown, and then you have to maintain patency. And so you read about it from that perspective, the maintenance of the nasogastric tube, not the insertion of it, because that you'll cover next semester. Another thing that you are to know is that your patient is gonna have a ostomy. Whatever is the ostomy place, if it's a colostomy or any other one, you're gonna have to be familiar with the uh, different pouches and how to care for an ostomy. There is uh, the need to know of what do you expect to have um, coming out of the ostomy into the pouch. If it's a colostomy versus if it's a ileostomy, and your knowledge of what comes out of the GI system at the different levels of the GI system will enrich and inform what you're expecting. Your knowledge of what is the patient gonna lose if they have an ileostomy? That's the place where most of the vitamins are absorbed. So, what nutritional considerations you're gonna give to that patient? Expect that what you give as diet is gonna come out, and so how often do you empty an ostomy that's an ileostomy versus an ostomy that's a colostomy? How often is the ostomy gonna be filled? Um, know that when we talk about ostomy care, that fecal matter, if it leaks around to the surrounding area, you're gonna have irritation, and the stool is either gonna be more acidic or alkaline, and it's not the same pH as the skin, so obviously it's gonna be irritating. Um, so when they place it, usually you clean. Again, it's not a aseptic procedure. You don't need surgical asepsis. You just need to be clean, wear gloves. Usually you see them, they put a skin barrier before they apply the pouch. And the pouches can be either one piece or two pieces. Um, and you need to empty it definitely before it's half full or at half full. Um, and then you don't want the patient to have food that increases gas, because then it can't, the pouch can explode. And what else? Other talks you have to talk about ostomies is the different management when it comes to fluid intake. If I have an ileostomy and I'm expecting like 1,000 plus mLs per day. So how much fluid should the patient replace, and what should the patient watch for? You teach them that you're gonna watch for signs of dehydration, and you are watching for this. Um, how does the stool look like when it comes from there? So expecting greenish, bilish secretions to come from an ileostomy. We expect it to have some digestive enzyme, and that patient would be at highest risk of skin breakdown if the fluid leaks around, versus your patient who has sigmoid colostomy. Here, your stool is going to be more well formed. The consistency is similar to your regular stool. Um, you can regulate the bowels with this patient, like they can empty it and know the expectation when is it going to be filled. They may not even have to wear the appliance at all time. Patients manage this on their own. Um, what else? The same color and foul smell is to be expected, so you need to teach your patient those aspects. What is most important um, in these patients is their psychological consideration. Patients with fecal diversions, they need considerable psychological support, instruction, physical care. um, their self-image, is very important. Down the road after acute care, your patient is gonna need bowel training, especially a patient who has, either retention or incontinence. They can benefit from bowel training, and you would sit the patient in a habitual manner and daily, have them attempt to defecate at the same time each day, and use those measures that will promote defecation, like the sitting position, and after certain um, at certain times in the day, usually early in the morning, the incorporation of uh, proper fluid and food intake is gonna be of greater help. Um, um, we spoke about the older adults, and because we have the greater population in our hospitals, going to be older adults. Just learn the older adults management, and you have in box 47.13 the bowel retraining of a person of older age, and what do you do to help them out. Um, Fluid intake, we talked about this. Um, a patient that has diarrhea versus a patient that has constipation, what you're looking at, and if the patient has chronic diarrhea and is there at home, what type of food you're gonna encourage, and your book discusses that. Rice, potatoes, bread, bananas, um, are good food replacement. Of course, you're not forgetting the fluids, because diarrhea comes with the risk of dehydration. Regular exercise, walking, riding, swimming is going to stimulate peristalsis, so it's going to be a very good help in promoting um, normal bowel movement. Um, your patient um, that is having incontinence, your highest worry is their skin breakdown, and especially in those folds between the buttocks. And your patient who has frequent liquid stools is gonna have irritation. So maintaining skin integrity is of utmost importance, whether it's diarrhea, which is controlled, versus fecal incontinence, which is uncontrolled, or a patient with ostomy. You're not going to forget these, because they're all at risk of skin breakdown, because fecal matter, when if it contacts the skin and stays on the skin, is going to irritate. It contains digestive enzymes, and they accelerate skin breakdown process. So meticulous perineal skin care and prompt removal of the fecal matter will definitely prevent skin breakdown. So when we're developing the plan of care and we establish the goals through the patient's eyes, it's only fair that when we're evaluating through the patient's eyes. Does the patient feel that they're at the place where they want it to be, with constipation, with diarrhea, with their understanding of ostomies and ostomy care? Um, are they adopting the new dietary lifestyle and exercise lifestyle? And how do they feel about it? You may tell them um, um, multiple times of the benefits of them, but if they don't adopt the new attitude, and then your evaluation is going to be in on that aspect, not how good your plan is or was, how good your plan impacted the patient and patient outcomes. Again, we're talking about safety guidelines when it comes to bowel elimination, and one of the primary roles that we're ensuring is that we're ensuring patient safety, communication, involving the whole team, collaborating, involving the patient in making the decision, um, is going to be of utmost importance. Here, when we talk about bowel elimination, we talked about vagal responses. You have to pay attention to that. Um, and we talked about enemas and the importance of teaching the patient, if they do self-administer the enemas, that they should be in the side lying position, and that they never should do it while sitting in the toilet, because they may cause injury to the rectal wall. Um, and then, of course, always when you're delegating, know what can you and not can you delegate or cannot delegate, and the importance of infection control practices, um, the importance of really um, looking at the stool and see if there is anything abnormal in the stool. Is there any blood? If your patient reports something, to make sure that you go and look at the consistency of the stool. If your assistive personnel tells you, patient is reporting this, you have to go and really look at what is there. One of the safety guidelines also is that, can I delegate measuring and recording drainage from an angiotube? Can I delegate measurement of what's coming out of the ostomy? These are things you have to know that these are evaluation and assessment. So we don't delegate them to assistive personnel.
We're gonna use this collaborative learning activity if we have time in the classroom to revisit those kind of exemplars for this concept: urinary retention, stool retention, urinary incontinence, fecal incontinence, discomfort, urinary end bowels, and how you're gonna be able to assess your patient and what is the rationale behind what you're seeing. Okay, whether we're doing urinary elimination assessment or bowel elimination assessment, we are gonna include a history. A history that asks a patient about their eating habits, their voiding habits, their pooping habits, the drugs they're taking, the fluid intake. So the history is going to give you a lot of introspective into this patient, because these are very personal. Like they're the things that the patient um, tell you is going to give you a perspective on what is your nursing problem, what are you focusing on today, and what are you going to teach the patient, what are you going to help, how are you going to help the patient. um, The next element in the assessment is your real physical assessment. So your book talks about the 4 examination finding: inspection, inspection, auscultation, palpation, and percussion. You see in this slide we don't have percussion, because percussion is not something that you're doing as an RN. And one of the things you're not doing is the palpation that your book talks about rectal palpation. We don't do it as part of our assessment, but definitely inspection, auscultation for bowel sounds. You need to really listen, and in case, for example, the absence of bowel sounds is associated with ileus, hyperactive bowel sounds are associated with inflammation. And so these examination skills you learned and practiced in your health assessment class, so bring it on and into this into your medical surgical courses. For the most part, the lab tests, when it comes to urinary system, you're going to see urinalysis. It's a quick way of looking at the renal function, and you see, you're not expecting to see white blood cells. You're not expecting to see red blood cells. You're expecting a specific gravity within certain range, and the specific gravity is going to tell you whether your patient is overhydrated or underhydrated. And you're not expecting to see ketones. This is all these all can be deciphered from a simple urine analysis. If you want to know more, you'll do a blood test and look at the renal function test. And the basic function of the kidneys is the creatinine and the BUN and the glomerular filtration rate. If you're suspecting infection, you're going to be looking at urine culture, and the culture can also be applied in the stool. We can look for some certain infections in the GI system with doing stool culture too. So it's not really only urine culture. Occult blood is when they're looking for blood in the stool, and that will depict if there's any GI bleeding. Do we need to know the renal function test? Yeah, you need to remember that creatinine is a an indication of good kidney function, and remembering that it's anywhere between 0.6 and 1.2, remembering that BUN is between 10 and 20. Some references say 6 to 22, but we're definitely concerned if it's above 25. You'll see that the glomerular filtration rate, the GFR, is something that they look at, and it is it's sometimes differentiate ethnic background. So the GFR for black versus non-black is gonna be different, but you're gonna follow the normal lab value for this, and usually it's very indicative of how well the kidneys are function. In the urine specific gravity, you don't need to really remember the details, but just know that, you know, we could remember some of those, but we don't, knowing the specific gravity is a good thing, but definitely knowing that there should not be any red blood cells or any bacteria or any ketones in the, and or proteins in the urine would be enough for you. Um, Other methods of um, assessing the urinary system is the bladder scanner, and then that's an indication of whether your patient is having retention. But that is something you can do on your unit without anybody's help. But they may do bladder stress testing, and that's, you know, in the radiology department, and or urine flow studies or cystoscopies or uroscopies, um, ultrasounds of the kidneys, ultrasounds of the abdomen, also take some biopsies. On the GI level, like we said, you could do stool culture, you can do occult blood testing. We can also do scopes. You'll see every person above the age of 50 gets a colonoscopy, and that's, you know, one of the screenings for picking up on colon cancer. Simple ultrasound will show if there's so much gas in the abdomen, but CT of the abdomen will show other abnormalities. You see also they may do barium swallow where they give some radioactive material to visualize the GI system better, because the GI system is a little bit like contains so many hollow structures that you want, if you want to visualize nicely, you have to have it in Technicolor. One of the things I would pay attention is that when anytime you give any of those barium swallow test, you have to make sure that the patient's kidneys are okay with that, and then encourage the patient to drink fluids afterwards. Um, so these are the general diagnostic testing that you're gonna have, and when it comes to elimination. Some of the primary prevention efforts are focused on environmental factors. For example, making sure the water is clean, the food is clean, so you don't get those parasitic infections or gastroenteritis. Maintain hydration. Water is essential both for, you know, making sure that you don't have UTIs like we spoke earlier, but also that your stool is soft because you're well hydrated. Adding fiber. It makes the stool bulky and easier to defecate, but remember, with fiber you need to have fluid. Physical activity, we talked about the impact of mobility on urinary elimination, how it is one of the factors that we develop urinary infection. We also talked about physical activity and its complication with having constipation. You know, when we're less active, um, we're gonna have um, um, food sitting there, or like, you know, stool sitting there in the bowels, and the fluid, and the water and consistent is reabsorbed versus the hyperactive where it's going to increase the intestinal peristalsis and thus moving the fluid or the feces faster from the intestine, so you lose more fluid. It works both ways. So the last primary prevention is really encouraging regular defecation, encouraging regular toileting. Don't hold your urine, don't hold your stool, and so also avoiding certain foods that cause you discomfort is going to be helpful. The secondary prevention here, we said when you think secondary prevention, think screening. So colonoscopy is secondary prevention because you're trying to get if the patient has colon cancer before it gets worse. You're not preventing colon cancer, you're just picking on colon cancer. Occult blood screening, you're not preventing bleeding, you're just picking up on the fact that the patient has those, microscopic blood um, leakage. You see that they do Goyat-based fecal occult blood test, and that picks up really on invisible bleeding. Prostate cancer screening is going to also help with urinary elimination. Um, you should know that who gets the screening is dictated by the governing bodies. For example, screening for prostate cancer for men over the age of 70 is dictated by the USPSTF. You know, um, the screening for any patient above 50 for for the colon cancer is also dictated, and if even if it's negative, you have to repeat it every 10 years. The USPSTF is also the one that recommends a colonoscopy screening. Why would a person not do them? Insurance is one thing, fear of the unknown is another thing. And also, a colonoscopy comes with complications that some patients are really scared to undergo. Why see probability when I know for sure that that test is going to bring me some unfortunate complications. As you know, the elimination problems, any effort to deal with them is going to be a collaborative effort. Medications, that's collaboration. Any pharmacological agent is collaboration. Even if you want to use incontinence management, like give stool softener or give medication for diarrhea, you're going to have to collaborate. Nutrition, you're going to have to collaborate. Any invasive procedure, putting a Foley in, prepping the patient, getting an ultrasound, getting an x-ray, it all needs collaborative effort. So we're working with other teams when it comes to these interventions. Pharmacological agents, your patient's gonna get antibiotic in case they have any infection. Even if the infection is in the colon, you're gonna get antibiotics for that. Diuretics are more if the patient is not able to pee, and we're not going to talk about this because to talk about diuretics, you need to talk about the conditions that necessitate diuretics versus antibiotics. Your regular UTI patient's going to get antibiotics and then they can walk and live for the next 20 years without comorbidities. If your patient's getting diuretics, probably they have more than one underlying condition or at least one. Antispasmodics are medications that relieve the spasm and thus the cramps in the abdomen and in the bladder. So expect these to be prescribed similar to antibiotics. Your patient not necessarily going to have a chronic disease to get antispasmodics. Agents to manage constipation. These are the main indications you're going to see. More often, stool softeners, enemas, laxatives, stimulants, you'll see those. Analgesics also are medications you're gonna deal with for mild discomfort to any kind of pain. Urinary infection causes discomfort, and gastroenteritis causes discomfort. So you're gonna see your patient uh, getting analgesics. Your patient that has hemorrhoids will get some analgesics. So other than the diuretics, the remaining medications are just, your regular pharmacological agent that you're gonna see. Surgical interventions, we just know that sometimes you have to relieve that urinary retention or remove the renal stones. But nephrectomy and dialysis are gonna be things you're gonna deal with in future. Urinary diversion, they may put some stents in the ureter if there is blockage, so to keep the urinary system working. Prostate surgery, you'll see that done also whenever there's prostate hypertrophy, because one of the ill effects is that urinary retention. Bowel surgeries, we talked about colostomies and all the ostomies earlier. Sometimes the whole colon is removed. We're not going to talk about rectal prolapse, but hemorrhoidectomy is another thing you expect to see. Having hemorrhoids are kind of, varicose veins in the rectal area, and they're very uncomfortable, and patients may bleed. Not significant blood to the point that they're going to lose so much volume, but it is significant enough to cause discomfort and to have a rebound effect on causing more constipation because your patient is going to be in pain. So hemorrhoidectomy is an intervention that really removes that and make them feel better. If we get time to finish this, we may think of some of the exemplars. For example, urolithiasis. What do you think? Is this a bowel problem, bladder problem, both problem? Who is affected with this? And we'll discuss some of those problems and if we get time to discuss this. But I'd like to have this as an interaction. Okay, thank you.